AFMC is really known.
And also make sure
Welcome to this episode of AFMC TV. I'm Robin Ledbetter. Thank you so much for joining us. Today I have with me Dr. Christina Bethel. She is a professor at Johns Hopkins University in the Bloomberg School of Public Health and School of Medicine. Her research focuses on building and translating the science of healthy development to promote early and lifelong health of children, youth, families, and communities. Dr. Bethel, thank you so much for joining us today.
You're welcome. I'm really excited to be here with you, Robin.
Me too. And so tell me a little bit about yourself and your previous experience, and how did you get involved with the Center for Child and Adolescent Health?
Well, I started out thinking I had an MBA and PhD. I thought I'm going to go run one of these well-being health systems, right? That we were all envisioning back in the 80s, actually. And then I realized I got a fellowship to DC, and I realized there was no measurement or data on children, youth, or families to even figure out how we were doing. And all the financing and policy was in the wrong direction to promote prevention and well-being and really look at the whole child and health, which we were talking about back then. So I realized I had to go get a PhD and help fill some of the gaps in of measurement and data, and so that we could start to show what's possible, what the gaps are, and how our health system can transform to really promote the well-being of children, youth, and families. So we started the Child and Adolescent Health Measurement Initiative in 1996 and worked a lot to get some of the first measures into health system performance and the CAPS tool for kids with special needs and the National Survey of Children's Health that produces state data. So until we had data that reflected the aspirations for real well-being and how we could get data to states and communities to make sense of their own state and start to work together, we knew we weren't going to get anywhere. So I kind of got drug into, but I created the CAMI, and it's been 26 years later, and we're still going with our same mission to put children, youth, and families at the center of health systems quality and improvement, and to promote the early and lifelong health of children, youth, and families.
And you guys are doing some really incredible work.
We are. Luckily, we've been able to be successful in getting some of the, first National Survey of Children's Health with lots of measures that mean something. So we run the National Data Resource Center for Child and Adolescent Health, which puts sort of liberates data to you right there. Anyone doesn't have to be an expert to go on and find out in Arkansas how many kids experience ACEs by race, get the data, do things with it so you can be really empowered. So for me, it's all about liberating information to drive transformational partnerships. But we've also done a lot of research to kind of really have to prove what you think would already be known. So we already know the importance of community and family connections to the development of children, and the importance of addressing family health and social determinants and ACEs and relational health. But without data to show that that actually is the case, not just in bench science, but really at the population level, we wouldn't really be able to get attention of, state policy and all the things that have to be put in place, and even training providers and rewarding them and performance measures. So that's been a big piece of our work too, is to do the research on the data that we were able to contribute to getting out, so that we could say things like, this is how many kids are ready for school, 2 out of 5. And yet when their families are experiencing more resilience, which is impacted by their relationship with their doctor, where they feel heard and seen and supported for what they need, those families are much more likely to do all the things that are needed to help promote the child's flourishing, so they're ready for school, so they can have a better life. And so it's really important that you draw that line. So that's more the research piece, and then flipping it back to policy. So what does that mean for Medicaid and Title V and child welfare and home visiting and early care and education, and how they can work together to really, really drive the kind of changes that we know we need.
So you're on the ground floor in affecting so many things, and all the way up to policy. Are you seeing that in the South, especially in our area with Arkansas?
Oh, absolutely. I mean, first of all, I've been down there, but we've been talking for a lot longer. In 2018, I came down, and I would say that your state's awareness of the issues, and you have all these assets, all these systems already in place. And each one of them, if you look at them, are saying the right things about their vision, about what their aspirations, about even an understanding of the barriers. The main issue is working together and having the support and time and resources from the governor on down, and also to have the funding to create those strong collaborative relationships, because nobody can do it themselves. The pediatrician has a lot they can contribute, family physicians and all that, but they need to work with early care and schools and, you know, all the other systems. So there's a lot of awareness, a lot of aspiration, and yet you face, you know, some historical challenges and some difficulty with getting policies passed. But if all you did was build on what you have right now, you would find that you have everything you need. So I would say I have seen since 2018 that Arkansas has gone from the last in the nation in terms of rates of adverse childhood experiences, which is one strong factor in promoting early and lifelong health. There's a lot we can do about it, so I'm going to talk a lot about that. But you were had the highest rate in the nation in 2018 when I came down, and you're now at 44. So
that's better than dead last.
But it's movement.
Yes.
It's movement, and you're aware of it, and that movement will accumulate, especially if we add in a strong focus on positive childhood experiences, and these issues of community level mattering and belonging, not just for the people that we care about in the community and the population, but for the people who are in the system, so that they can create the relational systems of care where they really can effectively work together. So I think that we underestimate the importance of collaboration, partnership across sectors, with families, and keep engaging that trust and sense of healthy belonging and mattering. So we're going to talk a little bit about that too. But that to me, is great progress. There's been some movement in developmental screening as well. It's still about the average of the nation. You know, about a third of kids are receiving developmental screening. And then when they do, they're often not getting follow-up, but that's a systems issue. That's nobody's fault, really. It's paid for. It's required. There's performance measures. You would think all that would create a perfect storm, but the mechanisms that support providers in the systems on the front lines to do that aren't necessarily there, but there's tools and things we can do with that too. So I think it's on the right track.
And you've mentioned a lot about your research itself and an overview, but you're very data driven as well. Mm-hmm. So tell me how that has helped shape your focus.
Absolutely. So I'm definitely a scientist. I, follow with hypotheses and things like that, but it really got lucky because during the time that I was coming up in my career, there was already a lot of science showing that, you know, what are the factors that really go into human development and well-being. And so there was a lot to draw on and to see the gaps that we didn't measure. We didn't measure outcomes. And so basically I got very into data and measurement so that we could have the data available to be able to do the research, to be able to drive the policy and support the interventions that could actually address the factors that promote well-being. So I became very data-driven, but a bit against my will, and also how to connect data to money and systems performance. And so it became very much about systems change. But when you come right down to it, it started with how can we make sure children and families thrive? And we know a lot about that. So how can we measure how they're doing, measure something about the systems and communities they're in, look at what's really driving what, and then start to get a conversation and feedback loop going. And so the Data Resource Center for Child and Adolescent Health that we run is all about data. I mean, we get in the weeds of it, and you'd be amazed like how one variable, how much it is. But we do that so that you don't have to, so that you can just use it. And so for me, collecting data and doing research without using it to empower, and it is really not something I was going to be able to do, because I'm not interested in just producing research. I'm interested in action. And so we've been really lucky to be able to marry those two together. But it is very much data, but it's really to use data for everything that you can so that you can make time and space for the relationships back when we started, there'd be community partnerships like around community needs assessment processes that hospitals would do, but they didn't have any more data than census data, which is birth and death, what your characteristics are, and birth and death records, sort of birth characteristics and what you died from, but nothing in between. Like, how are you? And that's really the space that we were filling in. And also, how are the systems doing? So they, a lot of the systems will be, well, I think we're doing great in this area because we're working really hard and we care a lot. And so we have to put a gap between, I'm working really hard and I care a lot, but some days you have to step on the darn scale and see what's actually going on. And so we've tried to create that scale with a sense of empowerment. So it's not a fear-based way of sharing data back to the system, but wow, you did better than I did in that. Tell me how you did it. So part of having all the data where states can compare themselves is the same, collected the same way, so they can say, oh, in Mississippi this happened, and in Arkansas this happened. Let's learn from each other. So trying to really leverage the authenticity and the authentic care that people have by giving them information that they can get curious about rather than be punished by. And so that's a big piece of how we work with data as well.
And you mentioned Mississippi. You just got back from Mississippi. Tell me about that project.
Yeah, so Mississippi Thrive was one of the largest investments that came through a congressional mandate to invest in a low income, high needs state to promote the well-being of young children and families and to come up with a systems approach. And so they were a 5-year project, and at about year 4, they'd done amazing things around workforce development and working at the primary care level and, dealing with some legislative policy changes and so on and so forth. But they had not really put it all together in a framework that was coherent and that could then be embraced in like a coalition going forward. So we came in and really brought to the table not only all the data and resources and policy knowledge, but also some ways that really focused on engaging families. So that was their big commitment, is we are all clear that outside of collaborative relationships that really can be sustained across all the groups that have to work together, and that ultimately engage and build trust with the family and the child and the youth in the community, we're not going to make progress. So we work in that space of family engagement. So all the measures and work we do is about from the voice of families, which was missing before, and you combine it with other data. So what we did is we helped create something called the Engagement and Action Framework, which is really to create a statewide integrated child health system. And that's goal is to promote positive health equity. And so this is something I really want to talk about, is the importance of having positive health as our goal, not getting rid of bad stuff, but promoting something good. So flourishing, right? And I can define that for you, is what we want to go for, because that's where people are engaged in life, have a sense of meaning and purpose, really prioritize and work to become able to keep good relationships and contribute themselves and stay in the possibility mindset when things are hard. What can we learn? How can we, because we all come from a lineage of people who've been through a lot, right? So if we're here, we're survivors. We are from a line of people who figured it out. And when you study that, even anthropologically, they did it together. And they did it through understanding. And so for me, that's why the mattering and belonging piece is so important. But in any case, that's some of what, what we did in Mississippi. So what it has is a purpose, some goals, and the goals are really to create a universal all-in approach for all children to really just get the services that are already paid for preventive and developmental services in a way that really engages families, and that is a systems integrated approach. And then from there, it goes on to define an approach and, 21 policy levers that can be acted on now, and how do we use data and measures to help inform and drive the process. So it has a lot of pieces to it, including a partner landscape that shows what really is the existing role of all the different systems that are already there. And I know they're all there in Arkansas because they were in the room last time I was there, who know they need to be working together, but what can they really do? And I think the sweet spot is really around preventive and developmental services is a really strong place to begin, because every one of them, whether it's WIC or Head Start or child welfare or early care or home visiting, or of course healthcare, are all charged with similar things, but they can't do it without each other. So it's a framework to really drive, integrated systems approaches to really achieve positive health equity and flourishing.
And it sounds like it far reaches the state of Mississippi, even into Arkansas.
Oh, absolutely. So it was created, and HRSA ended up overseeing the grant that was awarded, or authorized through Congress. And so it was developed as a national model. So the way that we did it was very much with an eye toward making sure we address things that are consistent across states. So, for example, the performance measures for all of these partially federally funded programs. So the federal government gives money to the state matches it, but they're accountable to report on performance measures back to the federal government to maintain that money. So like the CCDF, which is the Child Care and Development Fund, is a lot of money that comes to states, the Medicaid resources and things like that, and early intervention and so on. So we also looked at all the performance measures and took stock of what they had in common, how they could be changed in order to, create more partnership, because nobody was meeting their performance goals, but if we showed them that. So we really worked hard on the things that are relevant to all states, that all states have these programs, all states have these mandates, all states have these opportunities. And we know all states have the need, because that's where the data keeps coming in to say, there's variation in how kids are flourishing and ready for school, but if no one's doing that great. So, we can all get in the boat together. So it is created as a national model that would be adapted, and all of those things adapted and adopted and adapted in different ways. But it's meant to be a guide for all states, including Arkansas.
And with potential to really change so many lives.
Yeah, exactly. And hopefully to inspire quick action, because, I don't know, I feel like I'm getting old. And yet, if you look at the data like I do, it can make you cry. And then especially when you look at the possibilities and the strengths in the system and the goodness of the people in the system. And so it really is about systems change and, creating that integration, because we owe it to our children and families as well as to the professionals in the field. So we need to get busy. So we're hoping it will catalyze faster action. So we did some of the hard work, so at least we can help jumpstart some other states in, looking at their state and going with some opportunities.
Well, Dr. Bethel, thank you for sharing a little bit about your research and the incredible things that you're doing that can so shape so many generations beyond us. It's really amazing. But before we go, I do want you to tell us a little bit about what you're going to be talking about at the ACES conference in August.
Yeah. I'm going to really be anchoring all of what I just shared back to the fundamental focus on the importance of relationships and belonging and mattering as the core of the success of our systems, of the core of the success of our families and how healthy they are, and also the lifelong trajectories of all people. And so it's a serious science. And I plan to really focus on sharing some of the good news about the opportunities to promote flourishing by creating a flourishing paradigm. So it's not a disease paradigm, it's a what's possible paradigm. So we keep our sights on creating flourishing. And then in the container of that, recognize what's in the way. And ACEs are a part of it, social determinants are a part of it, inability of systems to really perform the way they want to is a part of it. So what can we do about it? And when you look at what we can do about it, it comes back to promoting relational health in the system and in families. So I'm going to try to do a run around the opportunity, the gaps, and the possibilities, and then address those possibilities at all levels. So within the family, within the practice setting for those who are directly working with families, and then within the system and some policy. So I'll probably end with giving an overview of the ENACT framework, and but it's a little bit of an odyssey, but it's a story. So I'm going to be telling a story and hopefully inspire people, and really leave people feeling honored, and make some distinctions, because it's really easy to talk about terms, and there's a lot of terms going around these days, like relational health and social determinants and positive outcomes and positive childhood experiences, which is a measure we created to complement the adverse childhood experiences measure. And what we know is that most children with adverse childhood experiences actually they're more likely, but they do not go on to have as many problems, most of them. Why? What is it? Well, positive childhood experiences, which are real lived experiences, and most of the ones that are the most powerful, go back to the neurodevelopmental science, relate to feeling safe, seen, heard when things are hard. So we see that the challenges in our life are actually the opportunities for us to connect with each other in a supportive way, which actually builds the best positive experiences are when we're actually needing each other. So when that happens, but that's different than a protective factor, which could be something like families have enough money to eat good food and live in safe neighborhoods. Those are factors that can contribute to those positive experiences, but they're not the same. And then, that's not, and then all those are meant to drive toward flourishing, which is different than positive. So when you hear the terminology, it can be like it's all a big mush. So my hope is also to start to build some of the coherence across these different themes so that it's not so confusing and it feels really doable.
Well, it's so interesting. It's so important. And I know that not only our audience learned a lot today, but I'll be excited to hear you in person in August 3rd at the ACES conference. So Dr. Bethel, thank you again for being a part of this today. It's such an important conversation. And I'm so grateful that you had the time to talk to us and share a little bit about the research and important work that you're doing.
Yeah, absolutely. And I'm really excited to learn from all of you too and be inspired by you.
That's it for this edition of AFMC TV. And thank you so much for watching, and have a great day.